Hello, my name is Jesse Clanton, and today I'm going to be talking to you in a two-part series regarding the systematic workup of hepatobiliary conditions. As always, I like to follow the SCORE curriculum outline for general surgery. This is the most updated copy, and it highlights, as you likely already know, what's expected of anyone taking the general surgery board examinations or ABSITE examinations and breaks it down into core and advanced topics. I'll be focusing predominantly on the core topics in this section of the pancreas, and we'll also talk about benign biliary disease, where we'll reserve malignant biliary disease for part 2 along with the liver. So let's begin with pancreatic diseases. I'm going to talk today and focus on cystic lesions of the pancreas, which for many residents and even seasoned physicians give them a little bit of trouble recognizing which ones are more worrisome than others. We're going to talk about pancreatic neoplasms, and we'll also talk about pancreatitis. So in general, you may get approached with a pancreatic mass, and you may be asked either in written or oral board formats to evaluate a pancreatic mass. And while daunting at first, if broken down and approached systematically, this can be no problem at all. As with most things, start with a good history and physical examination. And I like to identify specific risk factors. I like to ask about the description and the duration of symptoms. Some of these may come to you without any symptoms at all, may be picked up incidentally on imaging. I pay particular attention to any history of pancreatitis or alcohol use that the patient may have. And I also want to know about a history of malignancy, both in the patient and in their family. And this is not just pancreatic malignancy, while that's very important, but I also will want to know about BRCA1 or 2 mutations or hereditary breast cancers, Lynch syndrome, Peutz-Jeghers syndrome, which may run in the family and all can have an association with genetic pancreatic cancers. As far as imaging, if they haven't already had one, I'd like to get a triple phase pancreatic protocol CT. And I find that's most helpful in evaluation of solid pancreatic masses. If the mass is a cystic mass, well, then sometimes an MRI may be more sensitive or specific, though in many cases you will end up getting both to confirm the diagnosis between CT and MRI. I'll also get some laboratory data when I'm evaluating any patient with a pancreatic mass, specifically liver function tests, tumor markers, including CEA and CA19-9. CRP and prealbumin can be helpful as well if you're considering surgical intervention for these patients. As I kind of mentioned on the last slide, one of the first questions you have to ask yourself is this mass solid or cystic? If it's solid, it makes me very worried that it may be related to a malignancy, though certainly some benign solid masses may be just scar tissue due to pancreatitis. But I really think a solid pancreatic mass is pancreatic cancer until proven otherwise. Cystic masses, on the other hand, may be benign or malignant or even pre-malignant, such as an IPMN. A pancreatic pseudocyst would be the most common pancreatic cystic mass, but oftentimes more investigation has to be done to figure out the exact etiology of a cystic pancreatic mass. I'll involve gastroenterology colleagues for almost all of the masses that I see. I would recommend this to anyone as well. Sometimes they may tell you in an oral board scenario that gastroenterology is not available, but whenever they're available, I use them. So for a cystic pancreatic mass, accurate characterization is incredibly important. Again, special attention in their history of physical examination to any personal history of pancreatitis, alcohol use, or I want to also know about a family history of pancreatitis. Maybe other family members have had pancreatic cysts, or maybe even pancreatic cancer. I'll ask specifically about symptoms of history of pancreatitis, or even symptoms they may not know that they've had pancreatitis, but symptoms such as abdominal pain, nausea, vomiting, pain radiating to the back that may indicate a prior episode of pancreatitis. I also want to know about any obstructive type symptoms, and these could be obstructive jaundice, but also gastric outlet obstruction. Imaging is going to be very important, whether it's CT scan or MRI or MRCP. And again, utilizing our GI colleagues with endoscopic ultrasound. I'll start off with CT or MRI and MRCP, and EUS is often very helpful to better characterize any lesions that you do identify in the previous sets of imaging. And EUS is useful because not only can you get imaging through EUS, but you can also sample the cyst fluid. And so whenever I talk to GI about getting an EUS, I'll ask for not only their impression of the imaging characteristics, but ask for a biopsy where they sample and send the fluid and evaluate it for both cytology and cyst fluid analysis. Now let's talk about a little bit cyst fluid analysis. This is incredibly helpful in differentiating different types of pancreatic cysts from each other. And there's three kind of key components you should always be looking for in the pancreatic cyst fluid. One is cytology. That's just your basic biopsy. You're looking to see, is there cancer in the specimen or even dysplasia? Anything with high-grade dysplasia or more, I'd be very concerned that there may be active carcinoma in the specimen that was just a sampling bias or error. And so those patients I'll usually recommend for surgery. Low-grade dysplasia, not all of those patients need surgery. And if they're young and fit for surgery, I'd strongly counsel them and that it would likely benefit them. But older patients or those with many comorbidities, may just be evaluated with further imaging and serial EUS exams. Besides cytology, the two types of fluid analysis that are most commonly done for these pancreatic cysts are amylase and CEA. With amylase, you're looking to see, is this a pancreatic pseudocyst? Obviously, a pancreatic pseudocyst should be high in amylase. Values less than 250 of amylase essentially rules out a pancreatic pseudocyst. CEA levels are more indicative of, is this a mucinous type of cystic neoplasm? This could be an MCN or an IPMN. Both, though, are pre-malignant types of pancreatic cysts. Values greater than 192, if you can remember that specific number, those rule in mucinous type of cystic neoplasms, as elevated levels are not often seen in pseudocysts or benign serous cyst adenomas. And so these are the ones that you want to either monitor more closely or sometimes even recommend surgical excision for. And as you can see from here, resection, this little chart breaks down CEA and amylase. In some centers, CA19-9 is used. We don't use that typically here in my practice. I think it's fallen out of favor, and CEA and amylase are a much larger focus, but some of the original studies did include CA19-9 as well. And resection is going to be indicated for any symptomatic lesions, concern for malignancy, including inability to rule out malignancy, and any mucinous cystic adenoma, mucinous cystic neoplasm, or IPMN in an appropriate surgical candidate. Now let's talk about solid pancreatic masses. Similar to cystic masses, I start off with a good history and physical examination. I want to know about their family history. A lot of the similar questions that we would ask for a cystic pancreatic mass. I obtained laboratory work, including CBC, CMP, CA19-9, which is probably the most sensitive tumor marker for pancreatic cancer, and a CEA. Staging